So, raised ICP, first of all, what we will discuss today is the tiers of management called raised ICP. What he has taken is actually the way it is, but there are a few things that I probably add on from what, to make it more clearer. You did put a lot of things on the board. You did talk a lot of things, but then in practical scenario, how do you actually manage this raised ICP and why it is in tiers of management? Till now, we always had management. We didn't have tiers. Now suddenly, why did tiers come inside? The tiers comes inside because CSF is raised ICP is not a single phenomenon. It's dynamic, very much dynamic. Okay, so what is now is not what is then. It is what, and it evolves. Since ICP evolves, it evolves in a situation where it might go from good to bad to worse. That's why you have tiers of management that says if it was good, if it becomes bad, if it becomes worse, if it gets worst, what do I do? That's why it has tiers of management. That's not the only reason. What you must understand in the tiers of management is, as you go from one tier to second tier, what's happening now is the risks of that particular management has gone very, very high. I'll explain this again. First of all, we are saying that the risk, the patient's ICP is going higher and higher. The ICP is going higher and higher. That's why you use A therapy at this stage, use B therapy at this stage, and you see C therapy at this stage. That's why you have tiers of management. The entire problem is because it's dynamic, you have tiers of management. Clear? But the more difficult problem is if safety is here, then as you go down and go this way, the safety actually goes down and down and down. The safety of care goes down. So if the therapy that you use here versus the therapy that you use here versus the therapy that you use here, the risk just elevates. The risk just elevates. Okay. And another thing that also occurs along with the safety is that the mortality and the prognosis of patients in this tier of management is very poor. So once you reach tier 3, if you reach tier 3, then prognostically, once you have reached that tier, those patients are not going to do well. You getting the point? So if you have reached this tier, it means to say that this patient is probably not going to do well. You don't have much in your hand. And that's why these tiers of management are made that way. You getting the point? So I'll explain this once more. Tiers of management are based on the severity of illness. The more severe you get, the more you escalate treatment. Okay? And that's because ICP is an evolving phenomenon. It's an evolving phenomenon. What is now the ICP is not the ICP after some hours, is not the ICP after some days. Are you getting the point? And that is the reason that the tiers of management have been established. Clear? It's not just to say that you have one therapy, you have second therapy, better therapy, or third better therapy. Others what you will say is, okay, let me use this. This is the best therapy here. Are you getting the point? If, for example, you would say broad spectrum antibiotics, narrow spectrum antibiotics, you say, let me escalate from here to here to here. You might say, okay, I don't want to take any risk, let me put the broadest of the antibiotic down there and patient will get better. It's not the same. The issue here is that antibiotic is not going to cause a problem to this patient. But here, this tier of management is going to cause a problem itself because the therapy is so risky. You understand? So when I'm escalating therapy, I have to be very careful. When I'm escalating therapy in this kind of cases, in permanent brain injury, the escalation becomes very, very, very controversial and very careful. Clear on this? Because you are exposing a patient to a risk now. You get the point? So understand why you have tiers of management? You understand why you have tiers of management? Clear? So ideally, what you should have? You should have tier 1, tier 2, tier 3, and then you have something that you don't know, which is tier X. We usually don't know. Of course, before that you'll have a tier 0. So the tier 0 is a non-negotiable. It is a non-negotiable. That means to say it's the fundamental care that you're going to give. It's the fundamental care. So if you don't do this doesn't make sense. Okay, it's fundamental care. Okay, when you say T0, it's actually fundamental care. And when I say fundamental care, means what is all this about? It is about the usual things that we do on all patients usually, and we do it better in these cases. For example, I want to put this patient on a 15 degrees propped up position. That's part of tier 0. I want to ensure that there is no hypoxia. Any patient that is in the intensive care unit, it's fundamental that you don't have hypoxia. It's fundamental that you don't have hypotension. It's fundamental. You understand? So this comes in tier 0, which says hypotension, hypoxia, neutral position, and propped up position. Okay, this is fundamental. This is fundamental for any patient. So this comes in tier 0. Right? Now, if I want to see what comes in tier 1, tier 2, tier 3, tier 4, you can remember like this. That tier 1, okay, is all about preventing worsening. Or this is preventing what worsening. Tier 0 is all about preventing worsening. Now, if I have a patient who's having a traumatic brain injury, or who has a stroke, or who has a tumor in the brain, okay, if I give him hypoxia, if I give him hypotension, it's going to be worsening that particular situation. You're not helping, you're worsening. So this entire point over here is to prevent worsening. You're getting the point? So that is, you are creating a problem, I don't want to create a problem. That's the thinking when you are looking at tier 0. That's why hypoxia, hypotension, all that comes over there. We have not even got into therapy. We have, at this moment, we haven't even got into therapy. We are just saying preventing worsening. Clear on this? Huh? When tier 1, what could tier 1 be? What did you say tier 1 had?
Start with osmotherapy.
So what do you think tier 1 is about?
It's trying to reduce ICP.
Edema.
Sorry?
Trying to reduce ICP.
Correct, but that's everywhere.
Yeah.
So what is different from this? And so you said tier 1 is osmotherapy? Huh? And what's tier 2?
Moderate hypothermia and hyperventilation.
You said hyperventilation, so I'll take one of those points.
Yeah.
Okay, I'll take hyperventilation. I'm just taking one of that. Okay. Now tell me the difference between this and this, what do you feel? Now you said, I'll just explain this question once more. We have to figure out what is tier 1 and what is tier 2, because in your you should be clear now that we know that if I go from tier 1 to tier 2, I'm exposing the patient to a higher risk. I need to know what is tier 1 and what is tier 2. Correct? If I put tier 2 therapy in tier 1, means I'm exposing a patient to an unnecessary risk which is not supposed to be there. Correct? Huh? So how do you remember this? So what is the difference? Osmotherapy and hyperventilation. Tell me the difference. What is going to happen here? Conceptually, what will be the difference? Conceptually, what is the difference? Any idea? Conceptually, what's happening is, at this stage, at osmotherapy, I am reducing volume inside the brain. I am actually reducing volume inside the brain. No? Whatever CSF is there, whatever you said, I am reducing volume inside the brain. Correct? Conceptually. Conceptually, the volume in the brain is coming down. That's why I am using all of these therapies. Conceptually. In T2, I am actually reducing blood in the brain. I am actually reducing blood from the brain. You get the point? I'm actually reducing blood from the brain. That's why it's called, it's tier 2, where I'm actually removing blood out from the brain. So now you can think like this, I'm removing blood out of the brain, that's why the risk becomes higher. The risk of ischemia and things like that becomes much more higher. You understand? So tier 2 is removal of blood from the brain, conceptually. And tier